Hi everybody, my name is Aditya Daftari and today we are going to discuss the issue of flat feet, twisted ankles and what they do. The talk will be approximately 25 minutes and we will just get right to it. So the first question we have to ask us is what happens in a flat foot? And the primary abnormality that we say occurs in a flat foot is that we have heel valgus. In other words, we have the calcaneum rotating laterally as related to the talus. And when that happens, there is obviously uncovering of the talocalcaneal, there is talocalcaneal uncoverage. And as a result of which, there is also subluxation at the talonavicular articulation. This leads to increased load on the posterior tibial tendon, as well as the calcaneonavicular component of the tibial spring ligament. As there is uncovering of the distal talus by the calcaneum rotating laterally, the talar head tends to drop downwards, and there is also dorsal subluxation at the talonavicular articulation. In the coronal plane, again, what we see is the calcaneum rotating laterally, the talus being less supported by the calcaneum inferiorly, and then there is uncovering of the navicular, which leads to increased load on the posterior tibial tendon, as well as the calcaneonavicular and tibial spring ligaments. And you'll also notice that the lateral compartment seems to be more narrowed, and therefore you have an element of subfibular impingement, which means there is impingement on the calcaneonavicular ligament and the peroneal tendons laterally. So what's the need for imaging in somebody with flat foot? We see flat foot all the time. So the first thing is we want to know the etiology of flat foot. So is it a primary flat foot? Is it a developmental flat foot? Or is it something that is acquired? The other thing we want to know is what are the effects of that flat foot? Is it on the posterior tibial tendon? In which case, is it tendinosis? Is it synovitis? Or is it an accessory navicular? Is it subfibular? Is there subfibular impingement? Do they present with lateral sided pain? Is it the cartilage? So is it a diffuse joint pain that is there? Or are there spurs that are impinging on other things? There's another thing that I haven't mentioned here, which is the element of subtalar instability, in which you start to see changes in the sinus tarsi. So when one is trying to assess the etiology of flat foot for a primary or developmental or even acquired conditions, the initial assessment is always clinical. You notice that somebody has a flat foot. A weight-bearing X-ray is always a good way to reconfirm that somebody has that, and one may see osseous abnormalities on weight-bearing X-rays. The MRCT play more of a role in confirmation and assessing the effects, as well as helping us to make plans on how we will treat things. Ultrasound is a great tool for looking at the tendons, especially in these conditions. So let's just look for a second in terms of what we do with when we're looking at MRI. The first step that we want to do when we're looking at a patient we're considering for anything is look at the alignment of the talus and the calcaneum in the coronal plane. Now, this is something that may not always show you something, because remember, these are not weight-bearing MRIs. These are just regular MRIs. But oftentimes, just looking at these frequently will help you to understand that something just doesn't look like it normally does. And here are just a variety of examples that I've shown you, which show you a progressive spectrum of heel valgus. So if, for example, we look at the first case, you can see that the distal tibia and the calcaneum are nearly normal in alignment. And then as we move on the screen from the left to the right, you can see there's increased angulation between the distal tibial shaft and the calcaneum, indicating a progressive heel valgus like we demonstrated in the first slide when we're looking at the biomechanics. The next thing is to look for any solid bony lesions that could lead to coalitions. And in these situations, one particularly wants to look at the anterior process of the calcaneum, where you can see here at the anterior process of the calcaneum, essentially you have the calcaneonavicular ligament, but in this case, you can see there is a bony spur along with a fibrous bar in somebody who has a calcaneonavicular coalition. The second and probably more common area is looking at the sustentaculum. And you can see here, normally the sustentaculum will be horizontally oriented with a dark signal band, which is fairly smooth on both sides. Whereas in somebody with a sustentacular coalition, you would see that line looking rather irregular, significantly more narrowed, and oftentimes you'll see it angulated superiorly or inferiorly, which would be indicative of somebody with a coalition. Now, once you've identified that there is or is not a structural cause for that flat foot, which is in terms of a bony coalition, we would start to look at the spring ligament. So the spring ligament has got two components: the tibial spring ligament, as demonstrated by the green arrow on the leftmost image, and the calcaneonavicular ligament, as demonstrated by the green arrow on the second image. And one can see how in patients with coalitions, there is significant thinning of the calcaneonavicular ligament, especially as it traverses that talar head. So when there is uncovering of that talar head by the talar head moving more medially, it increases the loading on that calcaneonavicular ligament, which then results in injury and pain associated with that. And anatomically, you can see that is exactly where the calcaneonavicular ligament would be, between the calcaneum and the navicular, as the name suggests. There's no ambiguity there. The spring ligament, as you can see in this case, where you have one marked out in red, and actually I've mislabeled these, but you can see the slender attenuated spring ligament marked in red in this case, whereas the image on the right, which has got a red rim to it and the arrow marks in green the ligament is actually thickened and edematous in that case, and that is the more symptomatic ligament. So the image on the left is normal, and the image to the right with the green arrow is actually the abnormal tibial spring ligament. Now, obviously, you can see that this is a subtle call to make. It's not something that's easily made, and oftentimes requires a clinical correlation of somebody having anteromedial pain in those regions. The next thing we would look at is for somebody who has subfibular impingement. So as you can see, as there is progressive heel valgus, the first image on the left shows you the normal subfibular space. The second image demonstrates how there is heel valgus and there is narrowing of the subfibular space. There's complete compression and crushing of the calcaneofibular ligament. But you can see in this case, the peroneal tendon itself is more laterally located and therefore not actually impinged in this situation. On the last two images, you can see that the peroneal tendon sits between the inferior tip of the lateral malleolus and the lateral margin of the calcaneum, even a slightly prominent peroneal tubercle, which results in impingement of the peroneal tendon. So you can see that here, and in this case, you can see the impingement of that. Now, the last thing that we're going to look at is the posterior tibial tendon, and you can see as there is increased loading with the posterior tibial tendon. Here I've demonstrated two images on the left, which show you the normal posterior tibial tendon on the axial and sagittal images. In the next slide, next image, you can see how there is non-insertional split within the tendon. In the next one over, you can see how there is an insertional signal abnormality within the tendon, so a small partial tear or tendinosis at the distal insertion site. Now, with this insertion, there sometimes is a chronic pull, and that can result in bone marrow edema associated with it. So you can see the insertional bone marrow edema. You may see an accessory navicular of varying sizes, which may or may not have bone marrow edema or syndesmotic edema. And then last but not least, one may see synovitis. Eventually, some of these conditions will end up leading to a posterior tibial tendon rupture, where you'll see the tendon retracted up in the retromalleolar groove. But in this case, what I tend to look at is I try to understand the potential role of imaging in posterior tibial tendon management. So if I see, first thing I do is I look for bone or accessory navicular involvement. And in this, the options are: is it normal? Is there bone marrow edema? Is there an accessory ossicle with no edema? And is there an accessory ossicle with edema? And the idea really being that if there is bone marrow edema, then there is probably not much that we can do except rest, reduce the loading, and wait for the bone marrow edema to resolve. On the other hand, if we have somebody who has involvement of the tendon, then I try to determine whether it's insertional or non-insertional. If it is, I then look at the tendon quality itself. So is it robust? Is there tendinosis? Is there a partial tear or a split? Is it a near complete tear or a complete tear? If it is a tear, then I'm trying to determine where the tear is, the gap, the size, whether there's a bony avulsion, what is the quality of the tissue, how big is the stump. And if it's more robust appearing tendon, then one can explore the options of PRP or steroid when that is there. If it is a very attenuated or not very healthy looking tendon, then obviously we may not want to intervene with a steroid or PRP, as we may just cause rupture. The last thing I look at is the sheath itself. So I look for whether there's simple fluid, synovitis, or tenosynovitis. And if it is simple fluid, then we tend to conserve because we believe it's more reactive. On the other hand, if it's synovitis, one might consider doing a steroid shot if the tendon quality is good. And if it is a tenosynovitis, but with otherwise robust quality tendon, then one could consider doing a PRP. So in summary, when we're looking at patients who've got pes planus, or we're looking at patients with flat feet, we want to understand the principles of flat foot biomechanics. We want to identify the flat foot clinically and also on MRI. We want to try and determine the etiology of it, where correlations can be challenging. We want to look at the structures that are affected by this, whether it be the posterior tibial tendon the most commonly, the subfibular impingement, the spring ligament. And last but not least, when we look at posterior tibial tendinopathy itself, we're trying to determine whether the primary abnormality is at the bone, in the tendon. If it's the tendon, is it at the bone-tendon junction, or is it at the non-insertional aspect and the tendon sheath itself? And then we want to see how these can help us in managing these patients further. Okay, I'm going to move on to the section on ankle instability. And here we're going to talk about three things. Why do we image ankle instability? What can we see, and how does that affect our management? So if we think about imaging an ankle sprain, I think all of us have had ankle sprains fairly often. And the question always is, why are we imaging an ankle sprain? So we can image an ankle sprain in an acute situation or in a recurrent sprain situation. If we imaged in an acute situation, it's primarily because it looks bad, or it's not getting better as often as we expected. And here what we're looking to see is it the ligaments that are involved? Which are the ligaments that are involved and how badly they're involved? If it is an osteochondral lesion that has occurred as a result of this ankle sprain, and then if there are tendons that are involved. On the other hand, if it's somebody who's recurrently injured, we're more interested in the quality of the ligaments. Do they need reconstruction? What work needs to be done on these? If it is osteochondral, how bad is the osteochondral lesion? And does that need particular help? And then last but not least, we're looking at the dynamic changes which could happen anteriorly or posteriorly, resulting in impingement, as well as the sinus Tarsi syndrome. Remember, the goal for all of these imaging tests are for us to try and understand as to whether we're going to manage somebody with just plain reassurance, or we require surgery or some sort of injection or intervention in the short term, which is followed by reassurance and physiotherapy. So when we're looking at patients with an ankle sprain, I think the first thing we look for is bone marrow edema and fractures. The importance of fractures is that the location of fractures gives us a good idea as to what kind of injury we have. So if you look at the Weber classification and you have a suprasyndesmotic fracture, then you're thinking somebody would possibly have a high ankle injury, which typically may require a surgical intervention. On the other hand, if you have somebody who's got infrasyndesmotic fracture or an avulsion fracture of the distal tip of the fibula, then you know that this is probably somebody with a low ankle injury, which could probably be managed conservatively. We oftentimes find translational bone marrow edema or non-displaced fractures, and the importance of these is that when you see these, they essentially tell you that, okay, somebody's got a low ankle sprain, but they've also got a microfracture or bone edema, which is going to take 6 weeks to resolve. So this is not a fracture that's going to resolve in the usual 1 to 2 weeks, and you can reassure the patient in that way. So bone edema is a clue to a condition that requires surgery, or it could be a reason why something will take longer to resolve. We also look at the talar osteochondral lesion or involvement of the talar head, because this can indicate progression to osteoarthritis if it is begun, if it is due to happen. From there, we move on to looking at the ligaments. The key ligaments to look at are obviously the high ankle ligaments. So you can see the images with marked in green showing the normal syndesmotic, anterior and posterior tibiofibular or high ankle ligaments. And the red arrows show you how there is an intermediate grade injury of the syndesmotic ligament. There's a full thickness rupture of the anterior tibiofibular ligament from its tibial attachment towards the right. And then finally, you have a syndesmotic ligament injury, which is significant here, an intermediate grade anterior tibiofibular ligament injury. And then last but not least, you have a bony avulsion from the posterior malleolus of the tibia with a posterior tibiofibular ligament injury. And when you have a bony avulsion that is sizable, then that's usually a reason that people want to fix those or put screws through the posterior malleolus as well. Okay. So again, high ankle injury means that somebody has a greater likelihood to head towards surgery. And if they do a surgery, the question is always whether they're going to just do a surgery that involves the fracture fragments, or they're going to have to put a syndesmotic screw in as well. The anterior talofibular ligament is the most commonly injured ankle ligament. It's important to understand that you will see this in varying degrees of abnormality. What's normal is here on the left. Sometimes you can see a stretched and slightly thinned appearance, which could be everything from a grade 1 injury, or in a more chronic case, a partially remodeled injury. You can see a thickened and intermediate grade 2 injury. You can see a full thickness tear in this grade 3 injury from the talar attachment. And then finally, when you have these injuries, you have capsular rupture, you have anterior talofibular ligament rupture, and you have leakage of a lot of intra-articular fluid into the adjacent soft tissues, which gives an ankle a really bloated and swollen appearance, and which is what makes it look much worse than it actually is. So you just have an anterior talofibular ligament injury with capsular rupture with a lot of swelling. And these are the cases where you may even consider just reassuring them, look, it's a bad ligament injury. It's probably nothing we need to do surgically about this, but let's just wait it out. So it is a good way to help you to understand the prognostic implications for these patients. The calcaneofibular ligament, you can see here in the green arrow on the left looking normal. And then in this patient on the right, where you can see not only is there an inferior tip lateral malleolar fracture, but you can also see that the calcaneofibular ligament is significantly thickened and edematous. We look at the deltoid ligament. So the spectrum of injury in an ankle sprain moves from the lateral to the medial side, and eventually you start to see deltoid ligament injuries. It's important to understand the normal appearance of the deltoid, which does have a striated appearance to it, but we're trying to look for a significantly abnormal appearance. So you can see here on the coronal inversion recovery of those black sequences, how the normal deltoid ligament looks like actually the Greek letter delta with the triangle, the tip of the triangle sitting at the medial malleolus. And then in the second image, you can see how there's bone edema from the osseous avulsion and how you can see the ligament is completely disrupted. On the other hand, on the images on the right, what you can see here is that normal striated appearance on the non-fat suppressed image on the, and then you can see a much more heterogeneous sort of distorted appearance of that deltoid ligament. So again, this indicates just that you have more significant injury pattern. Last but not least, remember when you're going into an ankle sprain, it is an inversion injury, and to bring you back, you need to evert your foot. And in that eversion process, the peroneal tendons fire. As the peroneal tendons fire, they may overfire, and they may result in injuries that happen to them as well. And the common things that happen are you may develop an avulsion fracture at the base of the fifth metatarsal. But other than from the peroneus brevis attachment, but other than that, you would see that peroneal tendon may have a peroneal tendon sheath injury because it just pulled against the sheath and the sheath gets sort of stretched. You may have the sheath tearing and the peroneal tendon subluxing out. So instead of being posterior to the fibula, it moves lateral or anterior to the fibula. And then you may see the tendon itself develop splits inside it. So on the coronal images, you can see this sort of on the rightmost image, that Mickey Mouse sign that we can see here. So you can see here, there's this little Mickey Mouse sign of the coronal images. Okay, so again, this peroneal tendon injury will indicate a more significant injury pattern. So when we're imaging ankle sprains in the acute situation, remember we're trying to understand which ligaments are involved, how badly they're involved, the element of osteochondral injury, and what happens to the peroneal tendons. Now, when we're imaging patients who have chronic injuries, we're looking to identify what is the status of the ligament itself. So you can see in this patient, the talar attachment of the anterior talofibular ligament is very slender and attenuated, as opposed and here as well. So we know that these are patients with chronic instability with poorly remodeled ligaments that may need reconstruction because they're failing physiotherapy. We also can look at osseous remodeling, bony fragments, which may need to be put back in or which may cause impingement. So structure of the ligament gives us an idea of should we reconstruct, how should we reconstruct. As there's chronic instability, there's always loading on the tibiotalar compartment, and you can see osteochondral lesions in the talar dome. It's important to identify the extent of these, the degree of cartilage loss, and whether sometimes in a primary versus secondary situation of osteochondral lesions, whether they're stable or unstable. The next phenomenon that becomes important for us in patients with chronic ankle instability is impingement. So whenever you have instability or the ligaments aren't doing their work and you're loading them, there is micromotion or sometimes macromotion at these joints, and these can result in a synovial thickening. So the joint reacts, synovium gets pulled, and you get synovial thickening. It can result in bony osteophyte formation, and then these changes of synovial thickening and osseous proliferation um, can also, and you can also have normal structures like accessory ossicles that are normally living there, but because of this exaggerated mobility, those structures also cause an element of impingement. And this impingement happens on the tendons or the neurovascular structures, producing symptoms. So if you think about anterior impingement, you have a patient who has chronic ankle instability. They have an anterior tibiotalar osseous spurring. That tibiotalar osseous spurring can lead to, if big enough, a bony block. You can also have a bony avulsion that could lead to a bony block. But more importantly, you can also have bony proliferative change that can impinge on the traversing superficial peroneal neurovascular bundle. So remember, the anterior impingement is not just about the bone causing a bony block. It's about that bone potentially impinging on adjacent structures, which could either be tendons, and in this case, very commonly, the extensor digitorum tendon, otherwise the superficial peroneal nerve, which runs in the same location. Um, so that sort of helps you to determine whether A, you have bony spurs, if they're causing bony blocks, and then you may do diagnostic injections to help determine whether they're causing bony blocks or they're causing impingement on a nerve versus tendon, and then whether you actually need to debride these or you can make other biomechanical changes like we've done is just tell people not to wear shoes that have got sort of high ankle coverage, but to lower local ankle coverage, or not to take the laces all the way to the back, but to take them slightly forward. Posterior impingement is something we see very commonly in athletes. Now, the thing with fast bowlers and with footballers is that many of them were born with prominent posterior processes of the talus, so prominent stiada processes, ostrigonums, and these were not symptomatic to them from day one. What has happened over time is that they have developed ankle instability because of the activities they perform and the injuries they've had. And then those lead to impingement on the posterior structures, particularly the flexor hallucis longus tendon. So you can have posterior impingement from that, and that again can be because of either overloading the bone itself, in which case you'll see bone edema, or you can have a tendon sheath effusion like a stenosing tenosynovitis of the flexor hallucis longus tendon. And here again, you can do an injection to determine whether it is truly the cause of symptoms. Sometimes that works with if you use a ankle stabilization program in association with that, but then sometimes it requires a surgical debridement. The last entity that I'm going to talk about is when you have ankle instability, whether it's high or low, as the load on the tibiotalar joint increases, ultimately the subtalar joint is also going to be affected. And as you have instability in the subtalar joint, you start to see affectation of the sinus tarsi ligaments. They keep getting pulled slightly. There's micro trauma to them. They develop mucoid changes, mucinous degeneration, which produces bright signal in the sinus tarsi. And that bright signal may just produce a globular bright signal. It may produce ganglion cysts. And those things can then lead to either impingement on adjacent structures, primarily the neurovascular structures running through them, which leads to those neurological symptoms of the sinus tarsi syndrome. So in patients with a more sort of chronic ankle injury situation, we are trying to determine which ligaments are involved, what is the quality of ligament involvement, and what is the quality of the bone. We're also trying to determine osteochondral lesions, how big they are, whether they're stable, unstable, and the extent of cartilage damage. Should somebody get an OS procedure, microfractures, should somebody get an ankle fusion. And then we're looking at the dynamic changes from instability, which lead to bony outgrowths, synovial proliferation, or just exaggerated effects of accessory structures like the ostrigonum or stiada process, which can lead to impingement, which is upon either the neurovascular structures, the tendons, or actual bony impingement, and then finally involvement of the sinus tarsi also, which can happen. So when we're looking at patients with ankle instability, we remember that ankle instability can affect the high or low ankle ligaments. The low are more common and less problematic. The high tend to be more problematic. Early imaging is usually done to exclude the presence of a high ankle injury and assess why the ankle looks worse than one would expect for a normal low ankle injury. Delayed imaging, on the other hand, is usually done to assess for the secondary effects of chronic instability, including OCD lesions, impingements, and assessing the quality of the ligaments themselves for reconstruction. Perspective on why we're being asked to interpret a scan is key to how we interpret that scan. So you must understand, are you dealing with an acute, chronic, acute on chronic, and how is the patient presenting for you to identify what is the key element, what are the key elements in the future management of the patient. So last but not least, I think what happens is we talk about a lot of entities like sinus tarsi, anterior impingement, posterior impingement, OCD lesions, subfibular impingement. We talk about all these lesions in isolation, but remember they're not in isolation. There is an underlying biomechanical process that is going on, which then results in these happening. So finally, in order to effectively interpret ankle MRI for flat feet or instability, it's important that we understand the biomechanics of these conditions, the potential management steps that are taken to address the problems that arise from them, and the role of imaging in assisting diagnosis and decision making in the management of these conditions. I'll end by saying that this talk is made for this conference, but it will be available, as with most of my talks, about 2 weeks later on our InnoVision Imaging YouTube channel. So thank you for your time, and I hope you have a great meeting.